Dear Chairman, ladies and gentlemen, thank you very much for the invitation to be part of this meeting, and congratulations for putting together this outstanding symposium and this meeting and this Congress. Congratulations to the organizers. These are my conflicts of interest and my disclosures, and obviously some of them might be relevant for this presentation. Our recent developments and the evolution in the surgical and adjuvant treatment of spinal metastatic disease are more and more aiming at reducing the invasiveness of our therapeutic concepts and also to tailoring the surgical concepts to the individual patients. And several areas are contributing currently in order to reduce the tissue injury and to supra-minimalize surgical tissue injury. And in the following 20 minutes, I would like to highlight, number one, the minimally access surgery and then personalized treatment algorithms for our patients. So let's start with keeping the as small as possible. And I believe that spinal oncology is the working horse, or is the right field, the use case for minimizing tissue injury, because this will inadvertently lead to a better adjuvant therapy and to a reduction in all the complications that are associated with surgery for spinal metastatic disease. The first strategies were aiming at limiting the classical open approach to transmuscular or percutaneous screw placements, and for minimizing the access to the spinal canal for vertebral body resections or transpedicular decompressions. Today, we can see a large variety of different one-stage and two-stage concepts which are using percutaneous or transmuscular coming more lateral. We are using expandable ports. Another concept is to place the screws percutaneously and to combine this screw placement with mini open anterior approaches, either retropleural or retroperitoneal, in order to access the vertebral body and to resect the vertebral body together with the tumor in a piecemeal way. Technologies that help us to be more precise and to really accomplish the minimally invasive concepts. And one of those is obviously computer-assisted spine surgery, where we combine spinal navigation with the perfect intraoperative image acquisition using 3D fluoros or CT systems. We also like to use these 3D reconstructive imaging modalities in order to confirm the right placement of the screws and the right insertion of the vertebral body cages. And this all helps us to optimize our results already in the OR and not have to bring back the patient when we realize a few days later that maybe the screw is misplaced or the cage. Another strategy is to use radiolucent screws, carbon fiber reinforced PEEK implants. We are using the screws and we're using the distractable cages, and this helps us to further improve on the planning and the follow-up of these patients and the planning for radiosurgery. Again, the use of these screws, which are not really visible on conventional X-rays, again calls for a good spinal navigation concept in order to optimize the placement of the screws. In addition to the minimally access, it's also important to triage the patients and to select the patients according to their pathology and to personalize the surgical concept of the individual patient. Our algorithm here in Berlin starts with the question whether there is a pathological fracture. If there's no fracture, the next question is whether we have to decompress either the nerve root or the spinal canal. If this again is negative, then we will go for radiotherapy. If, however, there is a spinal canal compromise in the presence of a stable anterior column, then a minimally invasive tubular decompression is the way to go. And therefore we are using these tubular systems which come in a paramedian or transmuscular way, and which allow to decompress the spinal canal with a limited access and a a possibility to perform a hemilaminectomy or a laminectomy, as in this 78-year-old patient with a B-cell lymphoma had a clinically relevant epidural mass at T11 in the light of a stable anterior column. The patient was decompressed by a hemilaminectomy through the tubes, and then the patient was treated with adjuvant therapy. If, however, there is a vertebral pathological fracture, and the next question is whether the spinal canal is, then the question is whether the spinal canal needs a decompression. If no, we will then ask whether if the spinal cord is not compromised, then the next question is whether the nerve root is compromised, and if so, we will resect the posterolateral areas, the structures like the facet joint, and this will be accompanied by a percutaneous instrumented stabilization, and the facet joint can be decompressed again through a tubular system, as in this 52-year-old female patient with a breast carcinoma, radicular pain at L4 on the left side due to this pathological fracture of close to the neuroforamen, leading to a neuroforaminal stenosis. Here the posterior aspect of the vertebral body was infiltrated by the tumor. Here we have performed a tubular facetectomy, decompression of the nerve root during the course through the neuroforamen, and then the small tumor with radiosurgery. If, however, there's no spinal cord compromise and no compression of the nerve root, then the anterior column, then it's a question whether the anterior column needs to be reconstructed in combination with the percutaneous instrumentation. So now it's a question about stability, and here the SIN score is used. If the situation is stable, then a simple kyphoplasty will suffice, as in this patient with a prostate cancer, pathological fracture but still stable situation. If it's a moderately unstable situation, we will combine pedicle screw fixation together with a cement augmentation of the fractured vertebral body, as in this patient with a multiple myeloma. And if, however, the pathological fracture is obviously unstable, as in this two-level fracture at the cervical-thoracic junction, then a 360 reconstruction with an anterior support and a good posterior instrumentation is the way to go according to our algorithm. And if this is, and this might then be, this reconstruction also led to an indirect decompression of the spinal canal. And the last part of this algorithm is that we have a pathological fracture. The spinal canal is compromised, and the spinal canal and spinal cord needs to be decompressed. Then it's a question about the stability. If the spine is more or less stable, we can go with a percutaneous instrumented stabilization and circumferential decompression, what we call today a separation surgery. And this might then be combined with a radiosurgical concept. This is a 27-year-old patient with a breast carcinoma, multiple metastatic disease. Here the spinal mat is at T11 with an epidural compression, partial destruction of the anterior column, the posterolateral bony elements are involved, spinal canal is compromised, and the patient is developing a mild weakness of the legs with a Bilski free. So for this patient, we are performing first the instrumentation using the radiolucent implants, then a laminectomy with a resection of the posterior epidural tumor mass, and then it's really mandatory to perform a circumferential decompression with a resection of the posterior ligament and a resection of the anterior tumor. Not necessarily removing all the tumor within the vertebral body, but just creating enough space between the spinal cord or the dura and the tumor. Number one, to decompress the spinal cord, and number two, to have a large enough distance which will allow a radiosurgical treatment of the involved vertebral body. And finally, in our algorithm, the patient is suffering from a overt instability with SIN score more than 13 points, as in this case, patient with a melanoma, spinal metastatic disease at T9, fracture, epidural compression, Bilski free. And for this patient was initially treated at an outside institution They performed a simple pedicle screw fixation. However, and then submitted the patient to radiotherapy. However, the tumor progressed with increasing spinal cord compression. And for this patient, we first performed an embolization since the tumor was highly vascularized in our functional MR imaging. Then we did a posterolateral approach, an extracavitary vertebral body resection, replaced the vertebral body with a distractable titanium cage in this place. And then before that, we had placed our radiolucent screws and rods. And here, the intraoperative CT-based navigation was really helpful, and the patient could be treated with a conventional radiotherapy. And we believe that this algorithm really provides us with a strategy to perform a personalized, minimally treatment algorithm. However, there are cases, and we all know the cases, that are not good candidates for minimally invasive treatments. For example, these are multi-level metastatic disease with multi-level fractures, like in this patient who needs a much longer instrumentation and a much more aggressive and multi-level compression of the spinal canal is performed here with a 3-level above, 3-level below instrumentation and a circumferential decompression over more than segment. Or on the other hand, this 25-year-old patient with a triple negative breast carcinoma, single metastatic disease, many years following the initial diagnosis. And these are good candidates for an aggressive open approach aiming at an en bloc resection of the affected vertebral body. And we have combined this en bloc resection with the use of radiolucent implants, radiolucent cage, and the multimodality So in conclusion, we can say that minimally invasive technologies have really advanced, especially in spinal oncology, and spinal oncology is really benefiting from minimally invasive approaches because it will reduce the complications and will submit the patients much quicker for adjuvant treatment strategies. I've introduced you to our detailed and personalized preoperative planning and triaging of our patients. The concept is based on a large armamentarium of different surgical concepts that aim at sparing the tissue and that aim at tailoring the surgical concepts to the pathology, to the instability level, and to the spinal cord compromise. And instability is assessed by the SIN score, and spinal cord compromise is assessed clinically and by the Bilski score. It comes without saying that minimally access surgery is also an ideal strategy to prevent surgical site infections, and it comes without saying that as minimally invasive we are, the more rapid we can submit our patients to high precision radiotherapeutic concepts. And with this, I would like to conclude, and I'm happy to take questions. Thank you again for having me in this meeting.